just like to welcome to the stage Pete Ramsden from Rossdale's. I'm sure everyone knows him. He's a world-renowned race vet and has spent a career developing great relationships with his clients to try and limit these injuries we're discussing today. He also has numerous publications in the field of orthopedics and dentistry. So today he's going to talk to us about veterinary management in training yards to minimise the risk of serious injury. Thank you.
Morning, thank you. Hopefully this pops up. So I'm going to swing very much back towards the agricultural end of risk management. Right, we're away. So I mean, this is standard fare. Everyone understands this now, I think, but it's worth just starting with this. This fact that the majority, one still reads in the racing press after a high-profile injury or fatality that various quotes about it being a bad step and an unfortunate accident. I think it's fair to say that that can happen, but by and large, pretty much every high-profile injury that you can think of in the recent past has been preventable. So there have been opportunities to prevent all of these injuries, and that leaves wide open the possibility to prevent injuries, and one would like to rewind the clock on some of these horses in a way, but we are where we are. But the narrative very much is that that risk management and prevention of fatalities is complicated. So all of these risk factors lead towards fatal injury, horse factors, track factors, exercise factors, previous injury factors. So it's a very, as Tim's spelled out, it's a very complex landscape. And it's very easy to be discouraged by the gaps in the science. We know that there's currently no single screening modality that's useful in all situations. There's no consensus on some of the key features of fetlock imaging and what they mean for risk. We know that snapshot assessment is not particularly good at assessing risk. And that makes for a very tricky landscape for trainers, for owners, and for regulators to navigate. These challenges certainly aren't unique. We come across this and deal with this all the time in the pre-purchase situation, both at public auction and in private vettings, and also when we're asked to assess horses that we're not familiar with, say when a colleague is absent. And those situations, from those situations, we're very familiar with the reality that when you're viewing an animal for the first time, an animal you're unfamiliar with, you don't know the history, your assessment, your advice to the client is inevitably going to err on the side of caution. This is clearly a normal C3. This is a very dense C3. That bottom image is of a horse that raced to a late age successfully at high level internationally on several surfaces, carried lameness through much of its career, would have never passed a vetting from late 2-year-old. And yet, with the knowledge of that horse's history, medication history, action, it was very easy to be confident that this horse wasn't going to break and didn't. So that in itself underlines the importance of familiarity with the horse to accurate interpretation of imaging findings and clinical assessment. So the good news is that once you have that knowledge, that longitudinal knowledge, your assessment is far more likely to be accurate. And we also know that these pathologies are largely stress-related, so they develop over a significant period of time. Very few injuries occur without some sort of detectable change beforehand. and it's just trying to nail down what we can detect. So the classic situations are condylar fractures, but also that tibia on the bottom right there. One doesn't tend to see pathology that advanced for stress fractures of tibias, pelvises, but particularly tibias, unless it's in a yard that either ignores lameness or doesn't apply appropriate veterinary interventions. Additionally, we're fortunate in the UK that condylar fractures are the most common cause of fatal racecourse breakdowns. So sesamoid fractures are less common here, and complete condylar fractures are very preventable. So if you can pick them up before they become complete, then the horse has a better outcome. But even for the many jurisdictions in which sesamoid fractures are much more prevalent than here, if you can reduce your condylar fracture rate, then you're taking a big chunk out of your fatalities. And I think we have to be honest that, that there's still a huge amount of room for improvement in terms of how we apply imaging in the yard to horses. So on probably a weekly basis, sometimes more frequently, I receive images like those on the right, either as pre-purchase images or as risk assessment images. And you can see the pathologies on the left, from the pathologies on the left, that those images on the right are totally non-diagnostic. So particularly on that fetlock image, you might as well be x-raying the stifle in terms of how relevant that image is to detecting the pathology. So I think this, once again, that's a good opportunity for improvement. We can all lift our game, and until racing vets know how to take the appropriate shots, then we're really beating our heads against a brick wall. I mean, the number of times one receives images, a full set of standing images from a horse that's gone very lame, and the question is asked, has it injured its fetlock? And no one's taken a flex DP radiograph. I think we need to work on these areas. So, I mean, really the narrative I'm going to put forward is there's plenty of opportunity to further reduce injury rates, and it can be done in the yard. So for the most part, simple measures, not advanced imaging, can make a big impact, and the trainer's vet is perfectly positioned to do that. So where do we go? I think first thing to start with is which injuries are we talking about here. So we're not really talking about, when we're talking about serious and fatal injuries, we're not really talking about the wide sort of group of orthopedic injuries that racehorses can get. Chips, ligament injuries. These are things that are largely not preventable, but also that we're not talking about fatalities here. What we are talking about is serious or fatal injuries, injuries that might require life-saving surgery. And can we really meaningfully lower the risk? I think the jury's still out about whether we can lower the overall risk of injury. I think until more data comes out and until there's a better way to align risk data between yards and across jurisdictions, it's very difficult to say whether you're making an impact on overall injuries, but can we meaningfully lower rates of serious and fatal injuries? Certainly. So which injuries can we prevent? Condylar fractures, some serious pelvic fractures, and some carpal fractures. Other fetlock fractures, very difficult to prevent without advanced imaging at present, but all of these are within the realms of the yard vet. It's important to have an awareness about which horses are at greater risk of injury, and some of that is still an art, conformation, maturity, how the horse is taking its training. Those are things that both the trainer and the trainer's vet sometimes calibrate with little availability of science, but can be important. But also certain key periods in a horse's career are important to increase vigilance. So the weeks up to and including the first exposure to fast work, obviously, returning from a long layoff, certain injuries, particularly pelvic injuries, fragile horses, so horses that have had a track record of injuring something each training cycle, older horses with a lot of miles on the clock, and also horses going off campaigning in different jurisdictions, and that we know that there's increased risk associated with training on different surfaces. So also just worth giving some consideration to what is the risk period. So when you've identified an injury, how long is it directly relevant to the risk to that animal or the risk of serious injury? Is it the next gallop? Is it next month? And this, some of these things are unknown, but it's important to recognize that pathologies are dynamic, and you can't assume that once you've a diagnosis, that will remain the same for any meaningful length of time. The further you get away from your diagnosis and imaging, the less secure you must necessarily feel about that animal going into its next race. This is something I think it's hugely important, and familiarity with a horse gives you or gives the trainer a much greater capacity to manage risk, and also reduces the reliance upon imaging or diagnostic work. When you're asked to give an opinion on a horse's action and you've never seen it before, you can pretty much assume that your advice is going to be far less accurate than if you've seen it multiple times. Particularly goes for horses with history of known pathology. Hands and eyes, very important. I think once again it's subjective, but one can generally assume that pathology or lameness is arising from racehorses. Although we get a wide spectrum of injuries, most lamenesses come from certain places, and it's quite easy with experience to recognize the most likely starting point for any investigation, and also recognize which horses are high risk. So imaging is an adjunct to, rather than the primary way to risk manage as a racing vet. Vigilance includes pre and post fast work, not just racing examinations. In an ideal world, you would examine horses pre and post race. It doesn't necessarily take a lot of time, and it's not, while I recognize this is not something available to all trainers have the ability to trot horses up themselves, and with or without veterinary involvement. And it doesn't take much time, and it allows very good assessment of how horses are taking their training. You don't need to know the whole yard. Horses in fast work, obviously more important. And you don't need to have an embedded vet. So all of those head lads standing there, just through observing horses trot up regularly, had a very good handle on even subtle hind limb lamenesses. So much is said of gait analysis, but not much is said about the great capacity of the human brain for recognition of patterns, and it's definitely the case that regular observation of horses trotting up in hand can lead to great consistency in assessment of lameness. A strong trainer-vet relationship is important. That doesn't mean that the trainer should be looking over the vet's shoulder all the time, but it's fair to say that the sort of relationship where the vet is only called in once in a few weeks to potentially examine a lame horse or inject a lame horse, those relationships are higher risk in terms of serious injury for the horse than relationships where the vet is shown everything head lads, assistant trainers feel free to show the vet horses that they're concerned about. And that inevitably leads to early detection of injury. The flip side of that is this only works when there's trust on behalf of the trainer that the vet is going to recommend interventions that are appropriate. So if the trainer starts to feel that every time they show a vet a horse, that will result in a diagnostic investigation or a horse taken out of training and a big vet bill, then they'll quickly learn not to show horses to vets. So this brings us full circle back to those carpal x-rays. So one-off appraisals are inherently inaccurate. And if one were presented with a horse pre-race jogging up slightly lame and a radiograph like the lower one, inevitably the vet would be recommending to the trainer, don't run. Equally, if that were a pre-purchase radiograph, the horse would not be purchased. Whereas information about the horse's action, previous medications, how it takes its training is invaluable, so more likely that the horse will be able to carry on safely. In terms of lameness, new lamenesses are important, and change in action is important, far more important than grade or severity. So a subtle but new lameness can signal a much greater risk than a more severe lameness that's been present for a long time. And then once you have a horse that's known to be lame, what do you do with it? So response to training loads is something that's vitally important to assess. Injuries, these serious injuries aren't bolts of lightning. We know that many of these pathologies take a lot of time to develop into clinical injury. And so intervening on day one or even week one is not the right thing to do in many cases. And often the smartest thing to do is allow the horse to carry on. Obviously, individual circumstances are important, but carry on and avoid fast work or racing until there's a better handle on where the pathology is coming from and how the horse is taking its training, and then intervene with imaging if the horse is deteriorating or if there's time pressure, obviously. And then not every lame horse needs a diagnostic investigation. So if you're monitoring action, then that can give you an idea about whether a horse needs to be subjected to imaging or blocking. And then not every lameness workup needs to provide a definitive answer for you to give some sort of risk assessment advice to the trainer. So it's often quite straightforward to rule out the top 2 or 3 likely pathologies or the important pathologies. And once you've done that, you can establish some certainty that might allow the horse to train on and buy you some time. It's also important to keep a very open mind. As I mentioned before, these pathologies are dynamic. This is a nice example of a horse, older horse, that had been lame for a long time, carpal lameness, blocked repeatedly to middle carpal joint, but trained lame, was heading off to an international season, and it was thought to be a good idea just to screen the fetlocks radiologically, just to make sure nothing was going to sneak up under the radar, and also with the knowledge that the horse would be out of the UK under the care of a vet who might not like the action. That revealed, as you can see, fissure in condyle, confirmed, activity confirmed on MR. So just always be aware that there may be concurrent pathology. You might be absolutely rock solid sure that a lameness is coming from a certain location, but it never hurts to rule out the fetlock and try and periodically reconfirm the origin of lameness by mixing local anesthetic in with medications, for instance. Important to take staff seriously. This is more on the trainer side than the vet side, but It's certainly the case that some astute staff can pick up changes in the horse's action and behaviour well in advance of when that horse might present with a clinical lameness. It's an old video, but it's if you watch the second horse approaching the canter, suddenly goes lame in front, markedly lame, jumps off and then canters fine. This is a really typical presentation for a humeral stress fracture. These horses quite often jog up totally sound for the vet, days on end, whether they're cold or warm, and yet the report comes back day after day, sometimes for more than a week, that the horse is jumping off lame, and they're invariably humeral stress fractures. I've been in the position of myself of not quite believing what's going on, because the horse in front of you is totally sound, and yet when bone scanned, these horses are close to breaking. So sometimes lameness under tack or lameness only observable to good staff is more dangerous than an in-hand lameness. So medication, all of this comes back to having your eyes open when you're looking at these animals and tracking their progression through training. And while medication has an important role in racehorse sports medicine, both intra-articular and systemic, once you've committed to that path, you're closing the door on being able to observe the horse's lameness. So you want to be reasonably sure of a diagnosis, or at least which direction the horse's pathology is going. So radiographic screening prior to medication is recommended. Monitor your response to interventions. And I think we should I think we're now moving into a phase where the trainer ringing up a vet only to have the horse injected at the sites that the trainer wishes to have it injected, without any prior knowledge on the veterinary side. I think that should be strongly discouraged. It's a high risk practice. And then I think we shouldn't be afraid of training lame. So sometimes it's quite often it's the best idea in terms of being able to monitor how a horse's pathology is progressing. I remember standing, I think, in this room some time ago, arguing strongly in front of the BHA for continued use of intra-articular medication. I actually think now that watching horses train without the widespread use of anti-inflammatories is a better way to risk manage in general. Always remember that the fetlock is the anatomical site we're most interested in. So if the only thing you do in a lameness investigation is rule the fetlock in or out, then you're already lowering the risk significantly. So whether this happens through imaging or blocking is sort of unimportant. Don't trust foot blocks. Many ongoing cases that present having blocked a foot and end up being prodromal fetlock fractures. And of course, there are difficult cases with intercurrent pathologies, ambiguous imaging, ambiguous blocking, but they're a small subset. They're unusual. So I think don't be discouraged by the fact that some of these pathologies are complex. Common things are common. Try and rule out the common things. So many horses, as we know, have chronic adaptive changes in the distal cannon. Most of these, so PODS and dorsal osteochondral disease, aren't associated with increased risk of catastrophic injury, but it's important to differentiate lameness and poor action, change in action arising from the benign pathologies, or the relatively benign pathologies in terms of fatal injury, from those that are precursors to fatal injury. Most of the time this can be readily done by knowing the horse well, by applying blocks and radiography. Once again, there are atypical cases always, but these are a small subset, and we shouldn't be discouraged from risk assessing fetlocks just because of the knowledge that some horses need advanced imaging. When it comes to imaging, precautionary x-rays are always a good idea, particularly for those new and sort of sometimes subtle lamenesses, sometimes only evident under tack, but getting worse with training, despite the fact that I think everyone gets bored with me banging the drum for the Flex DP radiograph, but you know, this has been around for decades now. It's only in the last few years that its potential has been fully realized. Easy, fast, can do it on the day of a race without sedation in most cases if needed. You know, when a horse is about to jump on the horse box, all of these horses have condylar fractures about to go pop at some point, whether that's in days or weeks, we don't really know, but they're all horses whose lives have been saved. And I think it's fair to say that in the same way that with tibias and bone scan, we learnt a lot from recognizing tibial stress fractures on bone scan and then going back to interpreting some subtle changes. That's not subtle, that's a fracture line, but some of the very subtle changes on radiographs have now led us to a position where we can readily diagnose tibial stress fractures on radiographs that we would have thought showed a horse not to have an injury even 10 or 15 years ago. In that same way, we've learnt a lot from MRI, and it's possible to It's possible to diagnose or start to diagnose or have a strong provisional diagnosis of a condylar fracture without even seeing a fissure. Looking beyond the fetlock, this is something that I think I find myself doing more and more, and I had a case last month where I should have done it. A horse that was pre-race a little bit close, trotting up behind, but had been on and off for some time, happily sent it off to the races, came back with quite a serious pelvic stress fracture, and I'm sure had I scanned it beforehand, I would have seen something akin to the middle image with that little bit of callus, and instead it's got a displaced fracture and now needs a long rehab and may not race again. Really easy to do, doesn't take very long. You saw how long on that clip. No sedation, no clipping. So for any horse that's shortening up its action behind or that has trainer or rider concerns, it's an easy, cheap intervention. Sensitivity is not great, but if you have any serious concerns, they're the horses you should be stopping and sending for a bone scan. Also beyond the fetlock, onto knees, very much, so unlike fetlocks where one can be fairly absolute about whether a horse has, after you've blocked, imaged it, whether it has an injury that it shouldn't be racing on or not, or whether it needs advanced imaging. Knees are very difficult, it's very difficult to be absolute, and all the horse factors and historical factors come into play much more than with fetlocks. In general, if one's to generalize, arthritic changes and chips are far more safe to continue with than with dense third carpal bones, and also the top joint is much safer than the middle carpal joint. So dense third carpal bones are very difficult to risk assess, impossible, I would say, unless you've got some of the changes in the say the second image and the third image. When you've just got a very dense third carpal bone, you can't necessarily assume it's an increased fracture risk. It may be a lameness risk, but it may train on fine to the end of its career. So clinical information is really important. However, those frontal lucencies, as in the third image there, they're high risk for slab fracture, clearly. The sagittal lucencies, as in the bottom image, tend to be good reasons for the horse being lame, but not necessarily a risk for serious injury. And then very anecdotally, I would say that I'm very cautious about medicating dense knees in a horse that's exhibiting deteriorating carpal lameness, or it's a really unscientific term, but a horse that's sore. So not necessarily a solidly lame horse, but a horse that's really coming off its front end, looking sore, coming out of its fast work sore. And I think they're dangerous horses to be medicating, and rest would be advocated for those. We haven't really touched on soft tissues, and the reason for that is these are serious injuries from the time they're detected. So there's sort of no preventing them. They're serious, they need long rehab. Where a yard vet can step in is when there's a desire by the trainer connections to carry on, and sometimes these are surprisingly chronic injuries that don't deteriorate with racing, and I think that's a slightly trickier area. I mean, automatically these horses should stop, but some inevitably carry on, and if they're being made to carry on, the vet does have a role and can advise on whether that's a sound thing to do or not. So that's it really, and I think if we can move on all or some of these points from the left side of the screen to the right side of the screen, then we're lowering our risk all the time of racetrack and non-racetrack serious injury and fatality. It all comes down to knowing horses, not blindly medicating, observing progression, imaging appropriately where deemed necessary, and ruling out the fetlock. And I think if we can move from that left side to the right side, a lot of the serious injuries that have beset the industry in the past won't be happening in the future. So the message hopefully is a positive one. While ever x-rays are being taken like this, then there are opportunities to improve risk management, and even, they're good x-rays, but recognizing that even improving on those, all can be done on the yard, on an unsedated horse, plenty of low-hanging fruit, and it's really within our means to reduce injury rates. Thank you.
Thank you very much, Pete. The plan is to take questions at the end, so we're going to break for coffee right now, if that's good for everyone.